Okay, good morning, everybody. It's my pleasure to talk about this research that involves ways to think about stigma and trauma among Black gay men, what they identify as African Caribbean or Black in the Canadian context, but also in other diaspora communities and in African communities. So you'll hear a lot about stigma today based on sort of the descriptions in the panel, so I'll just spend a few minutes talking about it. So stigma is a major obstacle to HIV care, both prevention and secondary HIV prevention, primary and secondary. For Black gay men or in Black communities, this idea of HIV stigma is not only just about HIV. It's also sort of intertwined with attitudes about same-gender sexual practices, right? The idea that HIV is here because gay men in Black communities are doing things that people don't approve of, that they frown upon, right? So it doesn't even require a gay man, Black gay man, to have HIV to experience HIV stigma. Because even if you're a Black gay man and an HIV negative, the idea that you're a gay man in the context of Black communities, people associate the impact of HIV with you just based on your sexuality. So these things are intertwined. There are many domains of stigma. There are many types of stigma. So there's same-gender stigma, HIV stigma, gender non-conforming stigma, but there's also various domains in them. So I'll just touch on them briefly. So felt normative stigma is the idea that many people in my community have this negative attitude towards people like me, right? Vicarious stigma is the idea that you've heard about things, negative things happening to people like you. Internalized stigma is the belief that you deserve these negative attitudes about you, that you accept it. Anticipated stigma is the idea that something negative will happen to you, whether it's happened or not. And then enacted is the actual discriminatory act, having experienced it in real life. So stigma is not just, how do you say it? People go like, what's the big deal? Everybody has negative experiences in life. Like, why spend so much time focused on it? So the big deal, one of the big deals is that stigma is stressful, right? Chronic exposure to these things actually have physiological impact on people's bodies. So this is just a diagram that shows that psychological stress actually initiates a cascade of inflammatory and immune responses that has impact on people's health, right? So it can make people more vulnerable to infectious diseases. People who have illnesses might have more severe and more frequency of clinical symptoms, and it makes it harder for people to recover from illness when the body is in this chronic state of stress that forces, initiates this immune response. So if we think about how the stress response system should normally work, right? So you're exposed to a stressor and the body reacts. So a bear is chasing you and the body does these things. You get increased adrenaline, you can run faster, your blood pressure is going high, and then the bear, finds somebody else to chase or he gets tired, whatever, so then the response subsides. But think about in a society where the threat does not subside, right? Where racism doesn't go away, where homophobia doesn't go away, where the stigma doesn't subside. So then the body is at this chronic heightened state of stress response that exerts what in literature they call a allostatic load on the body system, right? So the idea of being in a situation where the threat response, the response to stigma is always happening, the body is constantly responding, and actually makes the body systems weaker and more susceptible to infection. So this is just showing that part of what happens is how things from the outside get on the inside, right? So everything we perceive comes through the brain, and the brain responds to that in ways that we don't often see until it's too late, but it manifests itself through inflammatory processes that lead to things like, this is just an example, skin diseases, infections, so on and so forth. So one of my colleagues, Valerie Earnshaw, has studied this, and this is a diagram of her resilience model. And what she found is that stigma actually predicts HIV symptoms in people with HIV, gay men and men and people who aren't gay. But in general, people with HIV have higher symptoms, more severe symptoms, more frequency of symptoms when they've been exposed to stigma. And that the mechanism by which that happens is through stress. She also found that some interventions work for some types of stigma. So there's social support, adaptive coping, works to mitigate the pathway between anticipated stigma, like I think something's going to happen to me, and stress. But it doesn't work for enacted stigma, right? When something has actually happened to you, these things don't really have an impact on it. So other life events and circumstances can be traumatic. So for a long time and even now, the diagnosis of HIV was considered a traumatic life event, particularly during the times where it was considered sort of death was imminent. Stigma can be traumatic, homophobia-based violence. We know that stigma contributes to the exacerbation and severity of HIV symptoms, like I mentioned, through the activation of physiological stress responses. And so we need interventions that can interrupt the pathway by which HIV stigma actually exacerbates HIV symptoms. But gaps still remain on the best ways to do that. I did a study in Ghana, we're just wrapping that up now, and we found the same thing that Earnshaw found, is that HIV stigma was associated with HIV symptoms. But it was also associated in this group with not being linked to care and not being retained in care. So that was curious to us. We also found that people who, in this study had very high symptoms. So they had high number of symptoms bothered them more frequently, and they were more severe. But even in the face of these symptoms, most of these guys were not linked to care and were not retained in care, which was puzzling, especially to me as a nurse, because if any of you have ever had any type of symptoms are a very powerful incentive to seek treatment, right? Because you want it to stop. You want the headache to go away. You want whatever it is to stop. But in the face of these symptoms, these guys weren't seeking care, and we couldn't understand that. In Ghana, if you have HIV, there's a mechanism in which you can get care, and cost becomes less of a barrier. So we talk to people, right? We try to figure out what's happening here. What we realized from hearing the stories is that it wasn't, how would I say it? When people told the stories, the things that weren't as consequential were vicarious stigma. Oh, I heard this happened to people when they went to this place. Or I think this will happen to me if I go to this place. Or I know most of the people out there think this thing about people like me. It was not getting in care and not staying in care was associated with having been in a place and something happened to you. So what we realized that it wasn't just the event that was making the difference, it was the memory of the event that was making the difference, right? So for a long time, we had thought these events are stressful. You go to a place and a stigmatizing circumstance happens and that is stressful. But for these men, what we were finding is that the sheer memory of the thing that happened to you was stressful. And it was so stressful that they were not willing to risk re-experiencing the event by going back there for care, right? So I didn't study memory, right? I didn't know what to do with this, but I realized that this was an issue. So I partnered with some folks who study PTSD. So what I've learned now is that chronic stress is just as traumatic stress. Many times when we think about traumatic stress, we think about catastrophic events, right? I was in a war zone, I saw somebody get their head blown off, or I was raped, right? People can clearly understand how those are traumatic events. But these other events, particularly around stigma, can be traumatic, and the stress symptoms associated with those are consistent with symptoms of PTSD, even without having a catastrophic traumatic life event. So this is just some diagnostic criteria for PTSD. So re-experiencing memories of the traumatic event, recurrent dreams, prolonged psychological distress when you think about the event, sort of what the guys were describing to us, trying to avoid reminders of the event, an inability to remember key aspects of the event, and then aggressive or reckless or self-destructive behaviors as a response to the traumatic stressor. So I'm just going to give you a quick lesson in the last 4 minutes. So this is how it works, PTSD, and what is happening. So the cerebral cortex is the main site for permanent memory storage in the brain. So memories are coded and filed next to memories that are similar to them. But these are sort of time and context dependent, right? The brain sort of gets rid of all the extra nuance that it doesn't need to know and stores the facts in its place. The hypothalamus is the central control center for the brain that also controls emotion, and it regulates visceral functions, like between fight or flight or rest and digest. So two systems are involved, the sympathetic system, which is involved in the fight or flight, or the parasympathetic system. And PTSD results when there's an imbalance between these two systems. The hippocampus is involved in parsing and recording the memories. So this is the part of the brain that says, we don't need to know this, we don't need to know that, here's what is meaningful and what needs to be stored. So it temporarily saves those experiences there and then stores them permanently later in the cortex. This is normally done, or this is done during sleep. The amygdala, which is the main site that is involved in PTSD, has a major role in processing emotional reactions. So it bypasses that route that takes the memory from the initial hypothalamus to the cortex of permanent storage and directly encodes it onto the amygdala, right? So this is because in a threatening event, the brain doesn't have time for you to sleep and figure out what this memory is and how to recall it. Like, it's there, it's ready to go when it encounters a threat. So in a routine experience, the hypothalamus evaluates the incoming stimuli and the circumstances, and then it sends it to the hippocampus, which takes out the stuff that it doesn't need to remember and records it. The memory is recorded during sleep through the rapid eye movements that happen when people are in deep sleep, and then it's transferred to the cortex for permanent memory storage, right? This happened, it's in the past, there's nothing to worry about. But in a life or death experience or a threatening experience, which stigma could include as a threatening experience, the hypothalamus evaluates the stimuli and the circumstances, but it doesn't send it to the cortex, right? It recognizes that this is a big problem. So it sends it directly to the amygdala where it gets burned in the circuit system and stored, right? It doesn't get integrated into the cortex for permanent memory storage. So what happens is that the person doesn't recognize that the event is not happening, right? If you ever have even heard stories about folks with PTSD, they can't even describe, why am I doing this, right? Because it's not a conscious process. The body recognizes the brain recognizes it, and it puts people into action, right? So there's the clinical intervention that we're currently working with in Ghana and in Toronto. It's actually going through IRB now, but it's called accelerated resolution therapy. It's an exposure-based therapy that incorporates rapid eye movements as a treatment for PTSD. This came from treatment of PTSD in combat veterans. So we were looking around trying to figure out who's doing work with memory, how are they doing it. This work has been going on for a very long time in the Department of Defense, but it hadn't made it into civilian populations. Actually, the only place in Canada where it was being used was in Alberta with first responders, so firemen or firefighters, police who experience traumatic events. So this is a brief summary of the protocol. So you don't have to have the patient talk about the experience, which is sort of the typical way that you enter into therapeutic processes is tell me what happened. So the person just needs to imagine what happened and recall the images and the sensations. So they imagine what happened either verbally or non-verbally. They go through a process of changing the image, saying this is the negative image that happened, here's the image that you want. And then through the use of rapid eye movements, which we believe mimics what happens during REM sleep, the rapid eye movement, that the memory gets stored from the amygdala where it is and causing these sensations to permanent storage in the cortex. So this is just a graph that shows the results from one of the prospective cohort studies. The red bar is the percentage of people with PTSD symptoms before treatment. The light green bar is percentage after treatment, and the dark green is the percentage 2 months after treatment. So you can see that in each of these categories, all people, age groups, and number of traumas, that a significant reduction in PTSD symptoms were found after people received this treatment. And then lastly, I'll just mention that these are some of the symptoms. All these symptoms were significantly reduced, but in particular, the PTSD checklist, sleep quality was improved, and depression was also decreased, as well as alcohol use on the audit scale. So we're working on this now, and I think we'll have time later on for questions from people, if not now. Okay,
so
thank you.
5-minute question.
Oh, and we have time for questions.
Thank you for that. That was amazing. Just a quick question. You were mentioning the event that caused the patients in Ghana to avoid going back to the clinic. What event were you talking about? Like the experience of their diagnosis or the event of their...
So it's interesting. That's an important question. Much of it was around the diagnosis, right? So, but it was not just the diagnosis. So I can think of an example where the person received the diagnosis, but there was other things that happened around that time. So one very bizarre example in particular was a guy who got diagnosed, and he asked the nurse what else could he do to manage his HIV. He sort of dealt with it, and she said, "I think you should buy some Pampers." And he said, "Pampers? Like, I don't understand why I would buy Pampers." So she said, "This activity that you're doing is not, your body is not, your bottom is not designed for this activity. So if you keep engaging in this thing, how will you maintain strength in that area? How will you control your bowels? I think you should buy some Pampers." So the guy was like, I was confused, like, I would need Pampers? And then he realized, no, she is like stigmatizing me like right here. And it wasn't about the HIV diagnosis per se, but it is happening around the time that he's learning about his diagnosis, that he's figuring out what medication he's going to need, and this person is taking him through this experience. And he was 22, and he talked about how humiliating and horrifying it was. And even as he's describing it, you can tell he's re-experiencing some of this anxiety. And he said, I can't go back. The fact that he's having to recall it and tell it to us is already giving him these traumatic-like symptoms, but the idea of going back to any clinic based on what he experienced at that clinic was too much for him. So that's like one example that always sticks out in my head because it's so far out, but most of it is around when they got diagnosed and the circumstances of how they were treated around the diagnosis event.
Wow, okay, thank you. That's a perfect example, thanks.
Yeah, you're welcome.
If there's no question,
So thank you for your presentation. It was really helpful to get a review about how stigma affects our inflammatory systems, PTSD, things of that nature. And there's also, we know that there's a lot of research around HIV and inflammation. And so specific question is, do we know if there's higher inflammatory markers around specifically with men of color, ACB men who are also HIV positive? And what would be some ways that this research could be applied to help decrease those inflammatory markers?
So I don't know if there are specific higher markers among ACB people. Part of what we're studying is whether or not using this treatment to treat PTSD can have a general effect of downregulating inflammation within people. Because the idea is that this inflammatory process is heightened and prolonged. And so this treatment might be able to have people sort of internally downregulate that process, which might have an impact on symptoms. So that's part of what we're studying now, is whether or not this has an impact not just on PTSD symptoms, but on HIV symptoms, if you can reduce the chronicity of those inflammatory processes. The other thing that we're looking at too is, because this has been done, it's probably been done with folks living with HIV, but it's not targeted. This intervention did not target folks living with HIV. So in the study we're doing in Toronto, we're targeting people living with HIV. So we don't know to what degree this intervention might be as effective, assuming that some of those people who take the intervention might have some HIV-associated neurocognitive disorder, right? Because this requires people to access certain parts of their memory, and it requires some degree of cognitive plasticity that we don't know how it might work when you target folks with HIV, either through prolonged medication use or this inflammatory process, whether or not this has the same impact that it has had on people, presumably most of them who've not had HIV. So that's part of what we're trying to understand, is how well it works with this population too. Thank you for the question.
Thanks.
You're welcome. Okay, thank you.